Susan, so thank you very much. It's always an enormous pleasure to be here. And again, many congratulations on all the work that you do. I've seen it develop over the years, and I think the association provides enormous support to all of you who have a child with Prader-Willi syndrome. In a way, my contribution to this really is partly through research and trying to improve our understanding of Prader-Willi syndrome, but also I think I've been psychiatric advisor to the association for many years, and I still get questions and queries by email and phone and so on. And I have to say, one of the pleasures, they can be very demanding, but one of the pleasures of doing that is one also learns oneself. And it's very nice when those of you, whether parents or support staff, contact me later and tell me how things have worked out, because that way I also learn, and it's nice feedback for me, particularly if it's worked out well. That's not always the case, I have to say, but anyhow. The title I've been given, essentially, so the main part of my talk is going to be about the journey that we've taken over some years looking at this new technique, or this technique called vagus nerve stimulation. But also I've been asked just briefly to talk about latest news and development. And I'm going to be rather selfish here. I'm going to also reflect on some of the research that we're doing and are planning in Cambridge. And we've got two colleagues here who will be available to talk to about that research a bit later. So I'm going to start by talking about the vagus nerve study. Then I'm going to talk a bit about, I've just come back from the Foundation for Prader-Willi Research meeting, which was in Las Vegas. My wife insisted that I left the deeds for the house at home before I went. And I have to say, I personally wouldn't recommend Las Vegas unless you were a keen gambler. But anyhow, the conference was very good. And then I'm also going to briefly say something about a meeting we had of the International Prader-Willi Syndrome Organization in Munich, then turn to some of our research, and also some general conclusions. Now, in terms of vagus nerve stimulation, I want to, as I think I've done in the past with research, is in a sense to try and take you through the journey that I and the group of us that are doing this work have gone through. Why we've done what we did. Because I think it's helpful to you to understand the thinking that leads to research, as well as looking at the outcomes of that research. So in doing that, I'll talk briefly about the first trial, then give you the findings of the second trial, and then look at how that has changed our understanding. And as you'll see in the story as it unfolds, that the thinking about vagus nerve stimulation, which first started as a possible treatment for the hyperphagia, the overeating, has now shifted to treatment for some of the behavioural problems. And I don't know what you feel, but in many ways the stories I hear from parents these days is that to some extent we can manage the effects of hyperphagia and at least prevent the obesity by good food security. But the biggest difficulty are the temper outbursts and those sorts of problems. And certainly the people that I, in the past and occasionally get to see now, are people whose placements are broken down because of these problems. So temper outbursts in people with Prader-Willi syndrome take particular forms. It may include physical aggression, it may include damaging property, it certainly includes verbal aggression, and may occasionally include self-harm. I don't have to tell you how traumatic and difficult those behaviours can be. Previous studies and our own study suggests that about 80% of people with Prader-Willi syndrome experience and may continue to experience and be at risk, if you like, for such temper outbursts for much of their life. I think there are interesting issues about whether the new generation of children who are on growth hormone, in which there have been early diagnosis and things, how much whether that will still be the case or not. But certainly when we did our study some years ago, the risk of the occurrence of temper outbursts was really very, very common. The way that I guess we think about temper outbursts and have thought about them is really in terms of what factors might predispose to that outbursts, what might precipitate those outbursts, and what might maintain them over time. And I think we've thought about things like delayed and atypical brain development. So some aspects of temper outbursts are a bit like what you might call the terrible twos. They're more difficult because your son or daughter is now an adult and the outbursts may go on longer and may be more severe. But they have some of the characteristics of the tempers that you see as part of normal development. Therefore, we've thought of this continuing risk as partly due to delayed development. But also we know from work with other people, particularly Kate Woodcock and colleagues, there's issues around emotional regulation. There's also issues around the ability to switch from one task to another and the great cognitive demand that requires of people with Prader-Willi Syndrome. Also things like unexpected change, food-related issues and so on, are all very important. I apologise for having to turn and look. I've just had an eye operation recently and my vision isn't quite good at the moment and I can't easily see the slides here, so I have to turn just to look at them. So that, I think, has been our understanding, and I think we've recognised too, and much of this is the work from Birmingham, that temper outbursts really have a particular characteristic, a particular course and resolution. They may be brief and long, but often there's a particular lead up to them, it reaches a peak and then it diminishes, and often there's great distress afterwards. I think in terms of intervention, I think to some extent we're struggling with that, partly because I think, and certainly the people that phone me about these things, is sometimes there's clearly a wish to have a simple and straightforward answer. And of course, when we think about straightforward answers, people often turn and think about medication, in the hope that maybe there is a medication that will somehow stop these outbursts. And one often gets asked to see people in which medication is used in a rather ad hoc and often inappropriate way. So one of the concerns in this field has been when it comes, and here I'm talking about, if you like, the behavioural outbursts, not the mental illness, that medication is used inappropriately. And the truth is there isn't a straightforward answer to these outbursts. Behavioural management, I guess, in the broad sense of the word, has been the main approach, trying to look, as I said earlier, about what might precipitate and predispose to these outbursts. But also, I think we've learnt over the years that food security is important, not just simply as a way of stopping obesity, but also it helps to improve behaviour. However, this has limited efficacy, and I said earlier, not only are behavioural outbursts common among people with Prader-Willi syndrome, they're probably one of the major factors, not only for parental stress, carer stress, placement breakdown, and so on. And particularly, I think, in terms of the person with Prader-Willi syndrome, for a poor quality of life. Now, if I now take you on the pathway that has led us to thinking about vagus nerve stimulation. Some years ago now, we became interested in vagus nerve stimulation because the vagus nerve, which travels from the brain to the gut and innervates the gut, the spleen, the heart, the lungs, it's a major nerve in the body. Because we thought, well, maybe if one overstimulated that nerve, we might have an effect on eating behaviour and cravings for food and so on. And it was of note that vagus nerve stimulation, which is used to treat epilepsy and has been used for many, many years, there were reports in the literature that people who were having vagus nerve stimulation for epilepsy, but who happened to be obese, some of them were losing weight, and some quite dramatically. And we asked, in fact, we had 3 people volunteered to have what at that time was an implanted stimulator, a bit like a pacemaker, in place. And we did this study, which was reported in this journal, the Journal of Intellectual Disability Research. And this study, therefore, was focusing on the overeating. But what we found is that there was really no effects on the overeating. These are the weight charts of the 3 people who took part. And essentially, they remain the same, although in this person here, actually the weight increased. So to our disappointment, there didn't seem to be any effect on weight or even on overeating behaviour. But what was very striking, however, was that there was a change in behaviour. And the 3 participants here who have given permission, and they helped us make a film. And this is just a tiny edited part of that film that describes, which you'll hear their parents and then one of the participants describe the benefits that they felt. And 2 people improved, and you'll hear the 2 mothers describe that. And the father described the person, Katie, who's the person on the right with the pink blouse, in which it didn't seem to help. But what they described, and this was unexpected, is that it improved their behaviour. And I'm showing this film because I think it is just very brief. It really brings home not only how difficult the behaviour problems are, but the real advantages when with the treatment of the behaviour.
Simon, Jennifer and their parents are keen to share their experiences to help you make an informed decision as to whether this study is right for you.
Big impact that has changed life at home. It is a lifestyle as well to go out and join in activities and clubs. You know, he has a job, he's in paid employment, it is part-time. I don't think Simon's been coped with that prior to the VNS. He is Mr. Chill, and I'm the only one that shouts in the house now.
I thought that's really moving.
It had an impact on her life because she felt more confident after all the travelling. She found the Jesus pool and went swimming and swam a mile, which was a tremendous achievement, and she was proud of that. All those things were very positive. She loved it. I don't think she gained anything from the insertion of the VNS. It was positive.
Well, partway through the study, bearing in mind at this time the study was focusing on weight loss. Well, we were seeing a sort of plateauing, we weren't really seeing weight loss, but we were starting to see a huge change in behaviour. And it took us quite by surprise, side effect if you like, but a very positive side effect. We had to sort of think about it quite hard. Was this really happening, or were we dreaming? Sure enough, no, we weren't dreaming, it was real, it was happening. All members of the family were beginning to notice huge changes. Jennifer was so much calmer, she was much, much easier to live with. Life was becoming, dare I say the word, normal? I know that's pushing it a bit far, but it was fantastic. The change was truly amazing.
Yeah, it's had a very positive impact in my life. You look at me living independently with my husband, that wouldn't have been possible without VNS, so that is one really big thing that would have definitely not happened without.
So every so often I speak to the families, and the 2 people who improved on the VNS, they both asked to continue to use the VNS, which I say was implanted in their case, and so that they've continued to have the vagus nerve stimulation from the implanted device. They continue to do very well. So that, as I say, was a complete surprise to us. We had started the study thinking it would help the eating. The problem, of course, was that we hadn't collected the data about behaviour. We'd only really collected systematic data about the eating. So there was a problem in sort of being able to convince people that this was a really effective treatment. So I think our conclusions from that initial VNS study was that really it gave us a new perspective on how we understood temporary outbursts in people with Prader-Willi syndrome. Firstly, I think it moved us towards seeing emotional dysregulation, some biological factors, as being critically important in understanding why people with Prader-Willi syndrome have this high risk for these outbursts. Secondly, it moved us towards something called the autonomic nervous system. That consists of the sympathetic and the parasympathetic nervous system, and it's a part of the peripheral nervous system, but it's the system that regulates our body and is the link between our body and our brain. So it told us, and the reason for that is the vagus nerve is part of the autonomic nervous system. So it told us this system was important, and there was a problem with this system in people with Prader-Willi syndrome. And secondly, it pointed us towards a new theory, a theory that was out there called the polyvagal theory, put forward by someone called Stephen Porges from America, in which he sees the vagus nerve as is moderating and mediating the way we as humans respond to threat. And I'll come back to some of these issues. But the point I want to make in taking you through, if you like, this research journey is how the observations are positive, both because it looks as if there might be a new treatment, but also they're important because they change the way we think about the possible causes for that particular problem, in this case, the temper outbursts. Well, there was, when we thought about the next study, we discovered that there was, in fact, a form of vagus nerve stimulation that could be done wearing an external device. And this device, as pictured here, is about the size of a mobile phone. And it's worn, and in the study, people wear it in an armband like the form that's used by runners. And then there's a wire that runs up to the ear, and there's electrodes in the ear, and it stimulates the auricular branch of the vagus nerve. And again, it's used to treat epilepsy. It's been approved for epilepsy. And for epilepsy, it's worn for 4 hours a day, either continuously or broken up into hour intervals. It doesn't have to be worn all the time, just for 4 hours a day. That is, if you like, the dose. So clearly, it seemed more appropriate to use the external device rather than have to put people through the operation and having an implanted device. Ethically and in every way, it seems right. I have to say, having done the next study with the external device, there were times I wished it was implanted so they couldn't switch it off or take it out and throw it away. But anyhow, you didn't hear me say that, but there are certain advantages when it's surgically implanted and can't be removed. So this has been the study that has now come to an end, and I'll be showing you the findings from that. So this study we did, funded by a combination of money from FPWR, the Foundation from Prader-Willi Research, from Sam's Foundation set up by Joe and Rob Gamby, and by the UK Prader-Willi Syndrome Association. It was about looking at the acceptability of this new device, but also its efficacy. Because clearly here was a different device that was stimulating a branch of the vagus nerve. We needed to know, would people wear it and would it have an effect or not. The other problem about vagus nerve stimulation is that both, whether it's implanted or external, the people who have it know that it's on. So for the 4 hours, the external device, you turn it up so you feel a tingling in the ear. The problem with that is it means you can't do a standard, what's called double-blind trial, in which you have some people having sham stimulation and some having real stimulation, and no one knows which is having what. You can't do that. So the methods we used here is that we asked the people who took part, first of all, to wear it, but not have it switched on, and what we call the baseline phase, and that lasted usually for around 4 months. And we asked the staff or the family looking after them to keep a diary record of behaviours, and we did various other assessments. They then had what we call the active phase, in which they were wearing it continuing to wear it 4 hours a day, but it was now switched on and they could feel the tingling in the ear. And then we had ethical approval afterwards, if they improved, the behaviour improved, to reduce it to 2 hours a day and eventually to stop it, to see whether any beneficial effects that had been noted during the active phase continued or not in this phase when we reduced it. So that's essentially the study design, those 3 phases with observations, diary records of behaviour, and our main outcome measure for the number of behaviours. And as I say, there are some other measures as well. So I want you just to think about this, and what we were interested in, therefore, is whether vagus nerve stimulation reduced these behaviours, and I've mentioned some of the measures here. We also had a measure of something called global attainment. We were interested to see whether, if behaviour did improve, were there benefits that went beyond simply the lack of problem behaviours. And so we used this particular scale to look at that. And we checked on safety. There has been some record of vagus nerve stimulation making sleep apnea worse, although we never found that in our first study with the implanted device. I should say we didn't find it with this study, but we're obliged, obviously, to monitor that. Sorry, the figures here are perhaps a bit small. through the PWSA and through our contacts, we asked for volunteers. And for this first study, we had to have adults who are aged 18 and over, and people who had the capacity to consent and understood the nature of the study. And 11 people came forward who met inclusion and didn't have any exclusion criteria for inclusion in the study. And that we identified these people, and we started 6 at a time, but we found that 4 we had to withdraw because and this is where I say there were times when I thought it would be nice if it was implanted, when they weren't wearing the device or things were happening, and really it was clear that even though they said they wanted to be part of the study, they weren't acting in a way that allowed us to collect the data in the way that we needed to. And one person had to be withdrawn right towards the end of in the middle of the study, because of difficulties in the home situation. But we had 6 participants who really went through in the end, of which 5 completed the trial. Now these numbers are small, but actually this is a very demanding trial. So you're having to visit regularly, or the person who's doing the work is having to visit regularly to support the people, having to support the staff and the families who are collecting the data. Of those who took part, and these are the numbers of the 5 who completed, just to say here, the compliance was very good. The machine tells you whether you've worn it 4 hours a day. And that's obviously important, because if it doesn't work, you need to know whether it didn't work because they didn't wear it or wore it incorrectly, or whether it didn't work because it doesn't work. Now this is the crunch thing, and these are the results, and they're reported on each of the 5 people. So each of those are the 5 people who took part. The white columns are the number of outbursts over a particular period of time in the baseline phase. And then these are the number of outbursts during each 3 months after in the active phase. So in A1, 2, A3, A4, they're receiving active stimulation. Now remember, for the treatment of epilepsy, vagus nerve stimulation takes many months to have an effect. So we were anticipating that any benefits wouldn't happen for a while. And in our first study with implanted devices, the benefits on behaviour took probably 3 to 4 months before we noticed any effect. Now you'll see in the 4 people who benefited that that's generally true, but by 9 months on stimulation, in all cases, of all 4, there was a marked improvement in behaviour. And to say those 4 people have all asked to continue on this stimulator, this NEMOS device, and we've let them have it, and we again keep in contact with them. One person is here actually today, and they continue to do very well, and the behaviours continue to be a lot less than they were before. This is someone I know very well, and it's not clear why the behaviours haven't improved, other than the fact that he is quite a bit older than the other participants, and I think there may be certain factors in the environment which may be, in a sense, maintaining those behaviours. But we're very excited by this. We think this is very positive, and the fact that it's being maintained is very positive. Now, we also had other ways of looking at this. This is using something called the Challenging Behaviour Inventory. So the higher the score, the worse the behaviour. Again, these are scores for each participant, and this is in the baseline phase. This is towards the end of the study. And what you find is the scores are markedly reduced. And in fact, they were 0 in these 2 people. Whereas here's the person who didn't improve on the basis of their diary score, diary records, and nor did they show any evidence of improvement on this form of assessment, this informant interview assessment. And very strikingly, when we changed the people from 4 hours a day to 2 hours a day, having improved, quite quickly things deteriorated, to the extent that we felt that we were obliged to put it up to 4 hours a day. And in fact, the ethics committee had said that if we saw any deterioration when we reduced to 2 hours a day, that we should indicate to them that if they wish to, they should go up to 4 hours a day again. All 4 were very keen to go back to 4 hours a day. They realised that something had gone wrong, that things were not as good for them and that behaviour had deteriorated. interesting, this person who hadn't improved, his behaviour seemed to have deteriorated further. And in fact, I don't think that it had deteriorated further. I think there had actually been some subtle improvements, but they weren't at a level that could be measured by the way we were measuring them. And I think at some point we might go back to this person and have a look at the situation again. Now, we also did a qualitative interview. We interviewed the family. In one case it was family, in another case it was the people who were providing support, and we interviewed them before at baseline, and we interviewed them towards the end of the active phase. And what this interview was to do was to try and get at the subtleties of some of the changes that were observed. So before, they were describing people having, these were the sort of common themes: uncontrolled mood, rigidity, the need to plan, because if you didn't plan it was a disaster, no opportunity for intervention. So they moved very quickly from minor irritation to major irritation, and you couldn't intervene, you couldn't persuade them to do their behavioural exercise or whatever it was. Whereas afterwards, not only did they say there were reduced outbursts, the person's mood seemed more stable, they seemed much more flexible, but also they gave opportunities for intervention. So if you saw that on the vagus nerve stimulation someone was getting a little upset, you could say to them, don't you think you should do your exercise, or don't you think you should do this? And they'd say, okay, and they would do it. So I think that's an important, very important, and I think these quotes really bring these things to life. If I can, in a way, he doesn't know what he's doing. This is talking about an outburst. He can't control it. But since the VNS, something clicks and he just calms. Before you couldn't challenge him on certain things, but now you can. He's prepared to sit and listen. She just seemed to accept the change. A few weeks ago, I don't think he would have. Routine will change a lot of times. The response is not as great as you thought it would be. So I can remember someone saying, a carer saying to me, we had to change the routine, and I was sitting there fearful of what the impact would be, but in fact, he coped with it very well. This is these global scores, and the higher the score, the better here. So this is at the active phase 4, so 9 months after stimulation. And this is the total scores, but you can subdivide them. And here people described improvements in the quality of life, reduced carer demands, and what they described carer expectations. So they really felt that a lot more was now possible because of these improvements. Now, what I want to do now is to focus on, I think for us, the outcomes here are very, very positive. There's the puzzle as to the fifth person, if you like, who didn't improve, but this seems to me very positive. It's one of the challenges, of course, is the long time it takes to have an effect. But the other side, as I hinted at the beginning, from a research point of view, is that it, again, makes you think about why. Why is it that someone with Prader-Willi Syndrome, people with Prader-Willi Syndrome, have this high risk? And it highlights yet again the role of the sympathetic and parasympathetic, or the autonomic nervous system of the body. It brings us back to this idea of the polyvagal theory, and the fact that maybe this is in some way moderating someone's response to threat. And the polyvagal theory basically argues that in evolution, the vagus nerve, this large nerve that runs between the brain and the organ systems of the body, has evolved in us humans to moderate the way that we respond to threat. Now, when I mean threat, in this case, what I'm talking about is the threat of a minor change. In the past, of course, from an evolutionary point of view, it might be the threat of being attacked, or the threat of, the threat of surviving in the environment. And what we think might have happened with vagus nerve is that it normalizes the way you respond to threat. So someone with Prader-Willi Syndrome on vagus nerve stimulation doesn't perceive threat in the same way. They're not as sensitive about these minor things, but even if they do see something as and I use threat advisedly, they are much more able to cope with it. So it's moderating this response. And there is some evidence that there is diminished parasympathetic And the vagus nerve is part of the parasympathetic nervous system. And the sympathetic nervous system is indicated here. These slides were prepared by Jess, who's been doing our vagus nerve study. She's much more able than I at finding these symbols on the internet. I wouldn't know how to do it, but the autonomic nervous system, in a sense, drives the fight response, whereas the parasympathetic nervous system helps to calm, helps to moderate that drive, this move to fight. And so what we think is happening is that this is being improved. And the interest, of course, is to return to this fact that the vagus nerve is also very important as part of the pathways that control our eating behaviour. And this has made us revisit some of that. And so this is just a very crude model. And what I want to illustrate is how, what I think we all do within the research community is say, well, what do these observations tell us? How do we modify the way we think about these problems? So there's what we believe to be abnormal vagal functioning. That in itself might alter satiety, and that maybe the fact that we think about people with Prader-Willi syndrome being in a state of hunger is that they're in a state, as any of us would be when starved or hungry, a bit irritable, very focused, more likely to move to this fight mode. And therefore, they're sort of constantly approaching this threshold in which they'll lose their tempers. And really, it's about somehow trying to alter this. So the outcomes of this trial, I think, show that T stands for transdermal vagus nerve stimulation, is therapeutic for people with Prader-Willi syndrome. Yes, it seems to be of benefit. One of the problems I've highlighted is it takes time. So if you've got someone with Prader-Willi syndrome, a lot of problem behaviours, can you persuade them to be patient enough and wear this device for long enough, for 4 hours a day, for some months, for the effects? Just to say that I think one of the very interesting things is that you observed with some of the people taking part in the trial that before their tempers were getting better, you had a sense that they were feeling better because they seemed much more willing to continue with the trial. So I don't think you have to wait for the full 9 months. I think a few months into wearing the device, people are feeling better and therefore much more likely to comply with it. So, as I've said too, it's really made us think about new ways to understand. And I think this new perspective really has highlighted the importance of emotional regulation, the role of the autonomic nervous system, and this idea of response to threat. So, I just want to take us back, really, to this idea of how we might link some of these behaviours that I've been talking about with this issue of overeating, the hyperphagia. And I've hinted at it in that previous slide, that the vagus nerve may be important, is important in both the eating behaviour, but also in the regulation of these other behaviours. And we've talked about people with Prader-Willi syndrome, we talked about the paradox of Prader-Willi syndrome, that it's as if they're in a state of starvation, but of course the reality is that there isn't, they aren't. And the problem is that they eat too much food if you allow them to do, but the brain is somehow fixed in this state. And that in itself not only, gives rise to overeating, as any of us who are hungry. Any of us would behave like this if we were hungry. But it increases food salience, so you're much more sensitive about food being around. If you see it, you will focus on it. And I'll come back to that a little bit when referring to one of the studies that is planned for the future. People who are hungry are more rigid because they're focusing on the fact that their task is to get food. That's the way we've evolved and the brain has evolved. You're hungry, you must get food because food maintains life, it maintains fertility. So women who lose too much weight become infertile. So from an evolutionary point of view, this is really very important. So it places you in a fight mode. You're not, when you're really hungry, you're not wanting to negotiate. You're wanting to get that food. And also interestingly, it probably creates a high pain threshold. Now, we've been looking at the literature here, but you can imagine that, again, from an evolutionary point of view, if you're out to get food, you don't really want pain to get in the way. And Joyce Whittington went back to some of our early data, and the more severe people's overeating was, actually the higher their pain threshold. So we think that this model might explain quite a lot of the aspects of Prader-Willi syndrome. Now, the next slide that I've inadvertently shown you is difficult to read, but I don't. That's not the issue. I just couldn't make the letters bigger and get all I wanted to in on the slide. But what I wanted to do was, in a sense, to show you how one tries to fit these things together. So the purpose is that I and others go to conferences to hear about other people's research, but we also hear about your own experiences, and we also think about our own results and our own research, and we try and think about, is there a model that would help explain all of this? And this is the latest way where, it may be wrong, I should say, but it's the way that research advances. It incorporates the new findings, it develops new hypotheses, and it then develops new models. And this is the latest for us. But I'm just going to take you through. So the issue, the fundamental challenge, I think, in Prader-Willi research is that you've got the genetics. We know about the deletion, we know about the disomy, and so on. How does the fact that those genes that are imprinted are not expressed give rise to all these problems that we've been talking about, as well as the growth hormone abnormality and so on? And so we've tried to look at what might be what we call the causative pathways. So we think there may be a relationship here with the fact that in utero, the child, the baby with Prader-Willi syndrome fails to thrive, doesn't grow normally, is very floppy at birth, and again, you can't feed, but later develops this overeating behaviour. And if you think about them in a state of starvation, we know that children who are in a state of starvation because of famine or whatever don't grow normally, they don't develop in terms of their secondary sexual development and so on. So maybe that explains this. It certainly may explain the overeating, but it may also explain the autonomic nervous system abnormalities. And we're also trying to look at some aspects that might explain, in the case of people with UPD or the imprinting center defect, what might explain this risk of psychosis, and I'll come back to that in a while. But the purpose of showing you this is just to, in a sense, give you some idea, I think, of how we try and advance. And that these ideas may be wrong, but what they allow you to do is to develop a new study. And I actually marked in here some of the studies that we're doing and that are there to try and test this type of model. And then you refine your model on the basis of these observations. So I want to now shift, and just to finish my talk, to move just to other areas. I was asked just to say a little bit about new developments and things. I'm not going to say very much about that, but I'm going to just show you, really, just briefly mention some of the discussions that took place at the recent FBWR meeting, the one I mentioned in Las Vegas. Interestingly, I realized when I made this slide that I'd spelt Vegas V-E-G-U-S, or V-A-G-U-S, and I thought, wow, that's an interesting mistake, really. But I think that there was a lot discussed, and I can't possibly cover it all. But I think the point to make here is that this is a really exciting time in the Prader-Willi field. I think that our knowledge is advancing really quite rapidly, and it's advancing really a lot of it because of models that allow us to better understand the genetics and the biology, the neuroscience, if you like, what's happening in the brain. It's very difficult to do some of these things in humans. So some of these can now be done, and have been done over some years, using these genetic mouse models of Prader-Willi syndrome, but also by techniques whereby you can take, for example, a skin cell from someone with Prader-Willi syndrome. In the laboratory, they can be converted to stem cells, and those stem cells can be converted into brain cells, and then they can be studied. And there's some really interesting work that comes out from this. So there was a lot of discussion about the basic biology, which I don't have a level of understanding to be able to go into that in any great detail, but just to say that I think is a very important and very interesting area. I mentioned one particular study. Now you'll be aware from, I think, Jennifer Miller's talk yesterday about the excitement about oxytocin and how things are perhaps moving back and forth a bit about the importance of oxytocin. But there was a very interesting study reported on here in which someone has been looking at, again using mice, looking at where the receptors, so the parts where the oxytocin latches onto and has its effect, are found. And one of the things they reported in looking at newborn mice is that they found when you stain in a particular way that the receptors were actually in the oral cavity, in the oronasal cavity. But they also found that the production of the RNA that makes those receptors was in another cranial nerve. The vagus nerve is a cranial nerve called the trigeminal nerve. And I think what it helps to explain that if there's an abnormality in that system, that might help to explain the problem with early suckling. And also, there's a lot of interest about how this suckling reflex is very important in terms of triggering future brain development and the development of social behaviour and the development of feeding. Now, I mention that because that is work done by a group in Florida, someone called Hammock, that is quite, at the moment, in a way, a bit independent of Prader-Willi syndrome. But I think it's very important to try and bring that work into the Prader-Willi field. The other thing that I think is very exciting, of course, the studies of the therapeutic or the pharmaceutical agents that are being developed to try and act on the feeding pathways and to control eating behaviour. And there were 4 studies of different agents to look at this, all of which seem to be having some effect. This is a new version of an older one, whose name I can never pronounce, and this actually some people will know seemed to have some benefits in terms of eating behaviour, but had to be removed, had to be stopped because of side effects and particularly because of pulmonary emboli. And one of the struggles, of course, with any therapeutic agent is to get the efficacy and the risks appropriately evaluated and understood. But I think the point here is not so much the detail, but there are pharmaceutical companies that are really working very hard at looking at and testing agents that are developed to act to try and prevent obesity, to control eating behaviour. And these are some examples here. So I now just want to briefly reflect on a meeting that the International Prader-Willi Syndrome Organisation organised and held under the aegis of the Professional Providers Caregivers Board, which is, if you like, a branch of IPSWO, which was held in Munich in 2018. And really, this was to try and bring together people from across the world, and I think people from 20 different countries attended that meeting, and to look at issues relating to social care and practice, and as well as health issues. And I have to say it was one of the most stimulating meetings I've been at, and it's amazing what you learn from other people. There is a danger, I think, that in the Western world, and I include Europe and in America and Australia in that, is that somehow we think we know it all. Or actually, we learned a lot from people. There was someone from Vietnam talking about their experiences in Vietnam, and you can learn a lot by just listening to what people have observed, what they're trying to do, the way they're providing support, and so on. And I found this meeting really very enriching from that point of view. But I just pick on 2 areas. There was a workshop in which people from these different countries were looking at the issue of restrictive practices. In other words, this issue of what right do you have, and do you have a duty to limit access to food? That's fine when someone's a child. In fact, you could argue that parents have a duty to do that in order to act in their child's best interests. It's much more problematic when someone is an adult because of issues that it's for us as adults to make these decisions for themselves. And whilst I don't think there is no easy and straightforward solution to this, there were some really, again, important insights as to the arguments you might make to justify the necessary restrictions in order to prevent harm. The other area that there was a lot of discussion about was ageing, and by ageing, generally people are talking about adulthood. When I think of ageing, I'm thinking of my age, which is towards the end of adulthood, but actually they were really thinking about adulthood, I think. And here, a lot of discussion about the health problems in adulthood, some of which are weight-related. Occupation and employment. And afterwards, I actually went on a visit to a group in Germany, and they're doing some amazing things there. And I visited a farm and also a factory where they've modified machinery so that people can have support employment. They can do jobs that otherwise they might not be able to do. But also there's a farm where people help looking after the cows and various things. It's not always easy to get this balance right, but I actually felt there was something there that we could certainly learn from. There were a lot of discussions about issues of relationships and discussions about issues of life expectancy and how one maximize someone's life expectancy. Now, the point I think about this is really that that partnerships and learning from others is really, really important here. And I think we're very fortunate in the Prader-Willi field that we have strong national associations, which UK is really one of the most important ones. But we also have the International Association, we have the Foundation for Prader-Willi Research, because there's always a struggle with rare disorders to get the resources and to develop the knowledge and to promote the knowledge that you need to. Now, in the last 5 minutes, what I want to do is just touch on some of the research that we're doing in Cambridge, and I hope you have a chance to talk to Suzanne and Lucy during coffee breaks and at lunch, and I know they were there yesterday too to talk about their works. So what we're planning at present, given what I've reported to you, is a further trial of vagus nerve stimulation extending downwards the age. We haven't quite decided what the bottom age will be. It may be as low as 8, but certainly down to 12. And we want to increase our numbers. And there's quite a discussion going on at the moment about whether we should modify the actual methods that we use. So it's getting a little frantic now. But we also want to focus in that trial not only on expanding the age group, but better understanding the mechanisms of action. And we've got a collaboration with a colleague in Swansea who's an expert on the autonomic nervous system, but also colleagues in Cambridge who are experts on using neuroimaging to look at these things. And also, as part of a wider group, we're extending our vagus nerve trials to other groups, and we're in discussion with the Fragile X Syndrome Society. And also, we're working in collaboration with a psychologist who works in the brain injury field. So that's one area, and this is being led, the person who's really involved in that is Jess Beresford-Weather, who would have been here today, but she's got the lurgy that Susan had, that I've had, and perhaps many of you have had. And she was at Las Vegas, and I spread it on the way out, and I think she spread it on the way back, because she had it on the way back. And we are looking for people, certainly age 12 and above, people with Prader-Willi syndrome, who may be interested, who have difficult behaviour, and who may be interested in being part of that. And if you think you might be, if your son or daughter might be interested, then do let Lucy or Susanna know, and we will approach you once we've got funding and once we've got ethical approval. Lucy, who's sitting over there, her study, she's been developing what is actually turned out to be, I think Lucy would agree, quite a complex methodology. And we've been working with experts in Cambridge how we use EEG, the electrical recordings in the brain, as well as how we use a new form of neuroimaging, something called magnetic resonance spectroscopy, to understand this risk of psychosis in people, which is much higher in people with UPD compared to people with the deletion form. Now, the reason I always stress when I'm speaking to audience that will include parents is that while psychosis is a tricky and not a nice illness, if we recognise it, there are treatments. And our hope of this research is if we understand more about what's going on in the brain, the chemicals in the brain that may be imbalanced, and we're particularly interested in two chemicals called GABA and glutamate, if we understood that, there are already drugs, the medications that act on those systems. So what we hope is that through Lucy's study, we'll much better understand what's going on in the brain that increases or protects you against this risk of psychosis. And in the long term, we hope it will be possible, if we really understood that we could suggest a preventative treatment. We could say perhaps to people with the diastolic form of Prader-Willi syndrome, and particularly if one began to see their behaviour deteriorated when they're in the age of risk for this, maybe this is the time to start some medication, for example, prior to the onset of the full illness. So that's another study. The study that Suzanne is doing is we're in partnership with the Baby Lab in the Department of Experimental Psychology in Cambridge, is really to advance the way we look at early infant development, and particularly look at this switch from under to overeating. My interest is particularly around the overeating. Susanna comes from a background which is particularly interested in early social development, and has been working in that field. And in a way, this study tries to combine those. And we hope that by doing that, well, partly it's to interrogate the model put forward by Jennifer Miller and Dan Driscoll about the stages of switch from under to overeating. We're not entirely certain that we think they're correct. We actually think that maybe this really floppy infant may already have an interest in food, and we want to see if the methodologies that Suzanne is developing will allow us to test on this. Her focus is on something called visual attention, as I say, to interrogate the Miller food stages, but also this might be important because if we can have a much more sensitive and accurate methodology to look at change, then we might incorporate it into an oxytocin trial. As you know, infants are given oxytocin, but there's great debate about the benefits or not of oxytocin. There are three of the important studies that we're doing, and again, if you're interested, although those of you here will be looking after adults, but if you're interested to hear more, please speak to Susanna afterwards. There is another study that we're working on, and I may be coming to some of you who are supporting adults with Prader-Willi syndrome to see if you can help us. And that is one of the things that became apparent in our vagus nerve study, is that actually, we're using paper and pencil to record these things like outbursts. That's really a bit of primitive in this day of modern technology, and we're looking to trying to develop an app that does two things. It allows us, informants to collect data about behaviour, but also it links to wearable devices. So I wear a Fitbit, but it links to wearable devices so we can look at physical activity, heart rate, that sort of thing, sleep patterns. And we can try and match those two together and better understand, you can see how that might link to the autonomic nervous system, better understand the relationship between observed behaviour and things like the autonomic nervous system. This is being developed in partnership with a Danish app development company called Monsenso, who specialises in the field of app development for mental health. They're also doing work with a social care provider in this country called HFT that also supports people with Prader-Willi syndrome. So they're developing an app there as well. But we want it really to support our trials and to act as a sort of a more of a diagnostic aid. And that's been done by Jennifer No, who's from Canada, and she's over for a year and will be developing this in partnership with Monsenso. But we will want to trial it, and we will want to talk to you and to people with Prader-Willi syndrome about what works and what doesn't work. So, what are my main messages? I think knowledge about Prader-Willi syndrome continues to advance at all levels, at the genetic, the cellular, brain structure and function, and clinically, and I would add to that socially, I think in our understanding of the types of support that people need. I think we're still missing a coherent model, if you like, a model of everything that somehow links the genotype to the phenotype, to the genes, to the behaviour, to the physical characteristics. And that's what that rather complicated diagram that you wouldn't have been able to see was really trying to do. I don't think there are any fundamentally new treatments as yet. We've had growth hormone for quite some time now, but I think we're, and people say this every time, but I think we're on the verge of some new treatments. I think the biggest challenge is actually still putting existing knowledge into practice. And you know, some of you, we've already talked to someone earlier today about this. For example, the issues of food restriction and food security in the adult environment, and the issues around consent and all that sort of thing. But also good practice in terms of behavioural management and so on, monitoring of health and so on. There's still, I think, major issues here. I think one can never get away from the fact, particularly in adult life, the central importance of quality of social care in delivering health interventions at the interface with social care. Poor social care will inevitably mean poor health, and poor health impacts upon the quality of social care. So that's important. The same old message applies, the importance of knowledge about the syndrome, food security to prevent obesity, hormone replacement, health monitoring and the detection of physical, behavioural and psychiatric comorbidities. That's a message you've heard many times. It's putting that into practice that, as I say, is the challenge. So I want to end really with, and I'm sure I'm preaching to the converted, but it's something that has become an increasing passion for me. And that is the issues of partnerships in our field. From us, our point of view as researchers, we really couldn't manage without people with Prader-Willi Syndrome, without families and people who support them. Because ultimately, if we're to develop new treatments, they have to be tried with people with Prader-Willi Syndrome. Or if we're to understand new treatments, we need to do the studies, the brain scans, the blood tests, and so on, in order to understand the problems. But it's not simply with yourselves and people with Prader-Willi Syndrome. And here I put this issue of new technologies. I see as one of my jobs is to ask, I can, if you like, think about the questions that need to be answered. But then, do we have the technologies to do that? And for me, neuroimaging has been one of the main things. I don't understand the techniques behind neuroimaging, but I know in Cambridge we've got experts who do. And so it's really very much a collaborative exercise. And Tony Goldstone and I have been involved too in brain scanning studies and at Imperial College. As Tony, I'm sure, will agree, we need physicists, chemists, we need a whole load of people who really understand the complexities. Funders, and I want to pay tribute to Joe and Rob Gamby who have supported our work, and one of the most important things is funding over time. Research is 2 steps forward and 1 back, but it is a steady move forward, and it's been really important that we've had core funding that's allowed us pilot work, it's allowed us time to develop our ideas, it's allowed us time to go and meet with experts in different areas and so on. I couldn't do, also I didn't mention here the UK Prader-Willi Syndrome Association, who have been immensely supportive in helping us approach people with Prader-Willi Syndrome and funding us in the past, and in many other ways. It's really absolutely critical. The National Prader-Willi Syndrome Associations, IPSWO, FPWR. And I want to just plug the next IPSWO international meetings. You know they occur every 3 years. The last one was in Toronto, the time before that was in Cambridge, hosted by the UK Association. The next one is in Cuba on the 13th to the 17th of November 2019. And as before, we have a clinical and scientific, a parents, and a professional care providers conferences, and we have activities for people with Prader-Willi Syndrome. And I think there are leaflets available. It's a long way. It's a nice place. I visited just to check out the place. Someone has to. It's a tough one. So, and finally, just to acknowledge the people who are doing the work and our collaborators, participants, funders, carers, associations, and thank you very much for listening, and I hope that's been of some help.
Thank you very much indeed. We've got a couple of minutes. Does anyone have any questions?
I just wondered when you talk about vagal nerve stimulation, I've looked up some of them videos when you first had them on, and was looking up any natural ways of stimulating the vagus nerve. You were saying about meditation
Yes.
and yoga. I just wondered if there's been any research into that at all.
Right, right. People are outside of Prader-Willi syndrome. There is really quite a lot on things like mindfulness, yoga, about if it has an effect, is that mediated exactly through that? You're absolutely right. And I think the answer almost certainly will be yes, it is. I think in the case of people with Prader-Willi syndrome, of course, there's a much more biological abnormality there. So whilst something like mindfulness may have some effect, it's unlikely to, I think, have a more permanent or long-term effect. But I think you're absolutely right. And the more, of course, once you make this observation, you do look at the broader literature, and then you realise people have thought about it. They're thinking about it in post-traumatic stress disorder, for example, is another area. But yes, I think a lot of this feeds through the vagus nerve. I think.
There's also like practicalities as well, trying to get someone to do.
Yes.
The meditation.
Yes. Yes. Yeah, that's right.
Can we just take 2 more questions?
Is there any link between the genetic type, disomy or deletion, and the vagus nerve research?
Right. I think I'm right in saying we haven't had a person in the study with the disomy yet. And of course the numbers are still very, very small. Am I right, Lucy? Yeah. So the answer, I don't know that. We are interested in that because the risks of the mental health problems are a bit different. And we want to really know whether the vagus nerve stimulation helps that, or could it possibly make that worse? And clearly that would be really important, but I can't answer that.
One last question.
It's me again. It was hypnotherapy being asked into that, so
I don't know of anyone trying that in people with Prader-Willi syndrome. I mean, I just imagine they go to sleep quite quickly. Right. Yes.
And he doesn't really like the method of going on medication,
Right.
as you explained in the beginning.
Yeah.
So he put it to the psychiatrist, is there any chance we could pay for it and have hypnotherapy?
Right.
And they just wouldn't hear of
No,
it. So
no.
would that be right?
I mean, I have to say I would be sceptical about hypnotherapy, certainly if it's a serious mental health problem. I would be sceptical because I think our experience is that mental illness can deteriorate quite quickly. And I think we do know when it's, if you like, the behaviour problems, and I think medication has little role, but when it comes to major mental illness, then rightly used, medication I think can be of great benefit.
it was the psychosis side of it.
It's the psychosis. So that I do think, we do have actually quite effective treatments for psychosis in the general population. I think the way you apply it when someone with Prader-Willi syndrome becomes psychotic is a little different. You start at a lower dose. You've got to be careful exactly which medication you use, and it can take you a little bit of time to find the right one. But when we followed people up who had been mentally unwell, most of them were doing very well, but I think almost all of them were still on some medication to keep them well.
And the side effects of the 3 medications.
Exactly.
Yes.
We really need to move on.
Yeah, that's one of the problems. Some drugs are better than others with that, and that's why I say you have to be careful.
Thank you very much indeed. Thank you very much, Tony. It's great to hear such advances that are being made, and I think particularly something that's got such a practical application.